Pediatric Assessment Course, Assessment of the Nose and Sinuses. Before we even touch the baby, we'll do some historical considerations and get a history of allergies particularly. What is the baby allergic to? What is the child allergic to? What foods, what medications? Is it in the environment, the pollens? What kind of facial injuries had the child had that may affect the nose and breathing? And what breathing difficulties has the child experienced, if any? A history of bronchitis, history of asthma, any of those kind of things. Epistasis, are nosebleeds. Has the child experienced any of these? And of course, sinus pains. Child complain of that, and how often and to what extent. The examination techniques we'll use for an inspection of the nose and the nasal cavity are inspection and palpation. The auscultation and percussion have limited value here. First of all, the nose is a fantastic organism. It is the entry of the respiratory system, and it's remarkable in how, whether you live in the Arctic zone or whether you live by the equator, the air that enters into the nose, by the time it gets to the lungs, will have been humidified, filtered at the right temperature, and will control moisture, put moisture into it or out of it to get to your lungs. So it's a superb organism for function of the respiratory system. First of all, you want to observe the nose. Is it straight? Is it symmetrical? Are there any deformities? Compare one side of the nose to the other. Does it deviate to one side or the other? And observe all these kind of issues. In respiratory distress, you'll often see kids flaring, nothing else but just nasal flaring. So be alert to that. We'll talk about the allergic salute, the allergic crease, allergic shiners, and Denny sign. And these are all characteristics of allergic components of the nose, such as rhinitis or sinusitis. You always want to look at the discharge of the nose as well. Is it purulent? Is it watery? Is it bloody? Discuss and assess the amount and the color. Remember that after a head injury, clear nasal discharge can suggest leakage of spinal fluid. It'll always test positive on the glucose test. Here is a nose. Here's a nose that is obviously asymmetric. After correction, it is still asymmetrical, and this is caused by the deviated septum or a fracture during birth. Here's an example of the allergic salute. Child that has the allergic salute will do this a number of times throughout the day with allergic rhinitis. It results in this nasal crease. Just above the end of the nose, you'll see this crease that is longitudinal or horizontal across. And again, that's caused by that allergic salute with a chronic allergic component to it. Look at the eyes for allergic shiners. Dark circles under the eyes will give you the hint to this. There is chronic venous congestion or melanocyte stimulation by the child itching and rubbing his eyes gives that darkening appearance. Periorbital swelling may be evident in kids that have rhinitis or sinusitis. Observe this swelling and record the amount and the edema that occurs. Here's a child with sinusitis that has a remarkable amount of sinus of swelling in the periorbital area. Here's an example of the Denny sign we were talking about earlier. These are prominent folds on the lower lid that runs parallel to that lower lid. It is associated with the itching and the scratching and the chronic, again, the chronic nasal congestion. Also, kids that have chronic irritation of the nose will have allergic rhinitis, will have this twitching or grimacing, facial grimacing. They often have disturbed sleep. They don't get a good night's sleep, and sometimes they don't grow very well because of that. They have snoring at night. They may have mouth breathing or dry mouth and coating of the tongue. Often these kids are irritable. They're fatigued at school. They may have behavioral problems because of this. And you'll also be characterized by this early nighttime cough. They may experience pressure over the forehead, the cheek, and sometimes the bridge of the nose. So as we examine the external nose, now we'll examine the internal nose. You can use the otoscope for this, or you can use a pen light. And most of the time you can just lean the head back, shine the light into the one nares and then to the other. Observe for any perforations between the two. If you shine the light on one side and you can see the light shining on the other side, we know we have a perforation there, and that child should be referred. You look at the, observe the septum and the mucosa. Color is important of the turbinates. The red that you'll see is normal, is typical in infection and inflammation. Allergy will present turbinates that are pale and boggy and gray, and purple sometimes with chronic rhinitis. Chronic conditions will do this. The turbinates normally should be pink and firm, and abnormally you may find some tumors or polyps. They're often associated with cystic fibrosis. And sometimes the red mucosa, instead of the nice pink and firm, may be from inhalant use or overuse of inhalant, sometimes nose picking in childhood, and sometimes cocaine use in the adolescent. Always assess for intact sense of smell with the older child. Here is allergic rhinitis, the turbinates in this, and you note how they're wet, they're boggy, they're grayish in color, and this is a chronic condition. Here's an example of the nasal polyps that you might find with a kid with cystic fibrosis. Sometimes they have difficulty with inspiration, and they'll often be mouth breathers instead of nose breathers. Here's another example of a nasal polyp, almost occluding the nares. You always want to, during your examination, test for patency. Now in an infant, you can take the stethoscope to assess patency, because you can't ask them to sniff. Hold one nostril and listen for the expiration of air, because remember, they're obligate nose breathers, so they're going to breathe out of their nose if they possibly can. Occlude the other side and listen to the patency on that side. If that's not possible, you can take a whiff of cotton, just a little whiff of cotton, and do the same thing. Occlude the one side, watch for the movement of the cotton ball to move back and forth. In older children, it's just easy to occlude one side and ask them to sniff for you, and they're delighted to do that. Always consider foreign bodies when you're doing an exam on children, particularly if there's an odor to the discharge. And also, typically the greenish colors, especially when it's associated with a vegetable that the child has put in his nose. Lack of patency can be indicative of upper respiratory infections, foreign bodies, deviated septums, allergies, or even nasal polyps can consist of this. Now kids will put anything in their nose, beads and bubble gum and all kinds of things. Most of the time you can ask the child just to blow outward. You can occlude one nostril and have them blow outward, and that can dislodge it. But occasionally they have to be sent to the physician, and a foreign body must be removed. These are some of the implements used to remove some of the things that are in kids' ears or in their nose. You want to palpate the nose along the ridge for the presence of the bone, and the cartilage should be smooth. You want to palpate the maxillary sinuses, the frontal sinuses, always above the eyebrows and on each side of the nose. If it's painful or it's tender, that can be associated with, again, chronic sinusitis. Now the sinuses are air-filled spaces. There's a total of 8 spaces. There's the ethmoid, the sphenoid, maxillary, and the frontal sinuses. Now the differences in children from adults are that at the beginning, the maxillary is the major air-filled space, and that is the one that is most palpable in a young child. The ethmoid sinus is also there. The frontal sinus is just a tiny little inkling of the frontal sinuses until about 7 years of age. And then transillumination and assessment of the frontal sinuses is very common at that point. Here's a scheme of the sinuses, and you can see that the ethmoid and the sphenoid sinuses are very deep into the nasal bridge and very difficult to palpate. So for purposes of examination, the examination of the sinuses would be the frontal and the maxillary. Frontal after 7 years of age, maxillary at the very beginning. Most noticeably, we can tap them, look for pain, tenderness, and put some pressure on them for that also. Sinuses can be assessed through transillumination as well. They don't always know what sinuses are used for, but they think they contribute to this, to the humidity and temperature regulation. One way to assess it is through transillumination, and we'll demonstrate that in just a minute as we pull back and turn down the lights a little bit. It's always important to get the lights lowered down so that the transillumination will show up a little bit better. Okay, we've adjusted the lighting now and lowered it a little bit, and we're able to do the assessment of the sinus tract using transillumination. The first one we'll want to do is the frontal sinuses. Put the just under the orbital ridge and get the nice configuration of the sinus tract. With occlusion, you're not going to have that nice round global glowing action here. These are the frontal sinuses, and then we can also assess the maxillary sinuses. To do the maxillary sinuses, we'll need to put the light right on the maxillary, kind of tilted toward the inward part, toward the nose, and assess in the mouth, on the roof of the mouth, for the glow inside that. Now, if she had congested maxillary sinuses, that area on the roof of the mouth would not shine through. So you look in the roof of the mouth for the glow, and that's a normal sinus, maxillary sinus. With purulence, you're not going to have that. With fluid, it's not going to be as transilluminate as that. So that's the assessment of the sinuses and concludes our assessment of the nose and the sinuses.